So essentially we identified that we needed to run these sims as a consequence of the many very necessary departmental and process changes that happened as a result of coronavirus. The main one being the splitting of the department into red and green EDs. There were some factors that we had considered and some that we hadn't in managing critically unwell patients, and that's really what drove us to organise these sims, essentially to test the processes of how we managed these patients when everything had been so turned on its head with the departmental changes as they were. We ran it as a real-time sim. We pre-alerted members of the PEDS resus team. That included obviously ED staff, so we made sure that everyone who was going to be around on the day that we planned to do the sim knew that it was happening. We also pre-alerted the paediatric team, the anaesthetists, the acute care response team, the resus officers and the porters as well. We managed to borrow a paediatric mannequin, a low fidelity mannequin, but one all the same, which had the capacity to have monitoring attached and a monitor on the side to make it more realistic in terms of what the observations were doing at that time. We also planned to put out a paediatric resus call in real life. We ensured that Switch highlighted that this was a simulation and not a real resus call. But again, we wanted to add to the sense of urgency that this was really happening. After the sim took place, we conducted a debrief with all of the members of the sim as well, to talk about what happened, to talk through the clinical scenario, but also to talk about any learning points that came up as part of it, and to identify actions going forward, and to allocate roles as part of that. We decided actually that this scenario would be best placed to be run in green ED, and at the time the PEDS HDU and resus cubicle in green ED as it was then was in one of the cubicles in fracture clinic. We created a scenario where a 5-year-old boy was pre-alerted by the paramedics unresponsive, having been found presumably having taken an overdose of his mother's antidepressant tablets. And the clinical skills that we tested were managing seizures and status epilepticus, identification of the fact that this was seizures in the context of poisoning and what the specific factors associated with that might be, the preparation of relevant drugs associated, so in this case it was benzodiazepines and sodium bicarbonate and fluids, and then also what we wanted to test was preparation for intubation, and we terminated the simulation at that point. So the first theme was environmental, so we found quite quickly that managing an unwell child with all the people and the paraphernalia associated with that, we weren't able to do that effectively in the cubicle as it was far too small. This links into equipment as well, and some of the equipment that you'd want to hand quite quickly, although we thought it was going to be there and accessible, actually wasn't, including, for example, there was no IO in the green area at that time. There was only one in red, so it involved having a runner having to cross areas, which obviously took a lot of time. What we didn't realise as well as a consequence of that was that there was an IO in one of the resus team's bags, but again, linking back to the environment not being suitable, we weren't able to establish that fact because key members were left outside the room. And that leads on to the second theme, which was of human factors. Everyone knows that PEDS resusses have got lots of people that need to be involved. And actually, because the room was too small, again, a lot of key members of the team weren't able to come in and participate, and they were sort of standing outside the door, which meant that the team leader, who could have utilised these people, didn't even know they were there, and so had to sort of manage on their own, as it were. The second thing is it's not really that clear in terms of allocation of roles and allocation of names, who was who. So it was fairly chaotic. The third point was clinical. So as I said before, the scenario wasn't really designed to test clinical skills, but what we did find in the scenario is it was just to make sure that you consult Talkspace for any poisonings, especially when someone's critically unwell.
It was really difficult to know where the line was and where to put on your PPE and what PPE to put on. So we decided that we needed visual clues for people when they're entering a hot zone, and so where they were going to have to put on full PPE, so put on the visor, put on a gown and long gloves. So that's what we came up with, these posters, and more signage to tell people what to do.
One of the main learning that came out is how difficult it is to identify everybody when you're wearing all of this stuff for PPE. So if everybody could just be aware that actually when you come to don on your PPE, if you're going into a resus situation, please remember these lovely little labels. So you can write your name on it and you can stick it on the front so that you're easily identified, which helps with our communication, which is obviously much more difficult wearing the PPE.
The main point that came out from the debrief was that everybody felt that they couldn't work to their potential because of the environment and the equipment issues. So what we did is we moved the PEDS HDU cubicle into green resus, which is where everyone's most familiar with it being anyway, where the equipment is readily accessible and people feel more comfortable. And we enacted that change on the same day. The second thing was in terms of using the team, trying to use stickers wherever possible to aid kind of decision making is really important. And thirdly, again, it's just a reminder about Talkspace and a reminder to use guidelines on the computers and the watch sheets wherever possible. And also, along with that, is to use all the members of the team who've got fountains of knowledge and they've got lots of equipment in the bags that they bring down with them that perhaps we don't think to use